Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone. This is James at GasGasGas. Today we sink ever deeper into our soporific, dozy, dreamlike, opiate-induced coma, and we are probably in the deepest yet safest coma to induce in a patient right now. We're covering RemiFentanil. This episode is going to be a bit longer because we're doing two things. We're going to make sure that we pick out all the important elements to know about the drug, but also we're going to talk about actually administering the drug, particularly going through its most commonly used pharmacokinetic model, i.e. Minto. I'm going to touch very briefly on not using a pharmacokinetic model for delivering Remi and why perhaps that isn't the best way of doing things. So naturally, if someone asks you about RemiFentanil in an exam, you're going to start by telling them that it is a highly potent synthetic opioid, and it is derived from fentanyl, i.e. a phenylpiperidine derivative. It is presented as a white, lyophilized powder containing remifentanil hydrochloride in a glycine buffer, and you will classically find it in 1, 2, and 5 milligram vials for reconstitution. You could also tell them the molecular weight's 412, but they're probably not going to be desperate for that information. Now, I have ranted on about how opiates work, and we're just going to hit it home again because you just need to be able to reel this off in the exam, smooth as butter, and move on. So it agonizes opiate receptors. These opiate receptors are G-protein coupled receptors with a GI subunit, i.e. they have inhibitory effects on the cell where you will find them in the membrane. It works to hyperpolarize that cell membrane, inhibiting conductance across synaptic clefts. It does so by increasing potassium conductance, decreasing calcium conductance, and inhibiting adenyl cyclase. Where is the chief effect of opioids? In the substantia gelatinosa of the dorsal horn of your spinal cord, in Rexed lamina 2, if you're going in that level of detail. You will also find a highly dense area of them in the periaqueductal grey matter of the midbrain. What are its actions? You guessed it, rip-roaring analgesia, sedation, and it stops your coughing. So you can breathe on that tube until the cows come home. And you can be awake and be very disinterested in breathing. And quite entertainingly, you can say, hey, you, take a breath. And they go, oh yeah, I should breathe. And then you have to tell them again, hey, take a breath. Well done, patient. Good, excellent. Keep doing that. It's just hilariously great stuff. Anyway, before I get terribly distracted, that lyophilized powder is readily soluble in water. How might you go about dosing remifentanil? So, classically, it is dosed as an infusion. Now, I think when remifentanil first came on the scene, people were just bolusing it to facilitate intubation and just smashing it in. And then we were getting people with rigid chests and perhaps some cardiac instability. So people have sort of wound their neck in a tad on that. Now, that's a lot of conjecture and perhaps folk tales, and who knows how much they were actually giving. I've seen doses of 4 mics per kilo given to facilitate intubation without relaxant to not terribly much ill effect. It would probably be smoother with slightly less of a peak if you were to just TCI the patient, and we're going to go over this in a minute, and turn that up instead. And if someone were to ask you, oh yes, but you're in the middle of nowhere and all you've got is a syringe driver as opposed to a pharmacokinetically enabled pump, what dose rate are you going to give in mics per kilo per minute? And the quoted range I've got is 0 to 1 mic per kilo per minute. So if you imagine if you've got a standard 75 kilo patient, you might be giving 75 micrograms per minute. If you were going at 75 mics per minute, that 5 mg ampule of Remi would last you about an hour. And you could say, well, why don't we just do that for everybody? And we will cover in a moment side effects. But we've given a dose. How long should we sit on our hands before it would take an effect? So peak effect is between 1 and 3 minutes. And you will find offset to be about 5 to 10 minutes, but obviously it depends on how much drug you've given. If you've given an absolute ton, then it's going to take a while to wear off, isn't it? Even though there's a rapid clearance mechanism, which we're going to go into details in a mo. To further quote a few ranges when we're thinking about a target-controlled infusion, i.e. utilising our dear friend Minto, you might find that 4 to 6 nanograms per mil effect site target facilitates decent analgesia during intubation and laryngoscopy. In patients who are having quite a lot of internal rummaging, say for example a laparotomy, you might be up into the 6 to 8 nanograms per mil effect sites. And the Oxford Handbook of Drugs Used in Anaesthesia and Critical Care quotes 10 to 12 as a dose rate required during cardiac surgery, because apparently sternotomies sting a tad. So we've thought about what the drug does to that person in terms of the beneficial effects, but what about the less beneficial effects of RemiFentanil? So remember now, we are going to split these side effects down by system because we want to look slick in the exam. So cardiovascular effects. It decreases your mean arterial pressure and drops your heart rate by about 20%. Therefore, you may expect to see a drop in cardiac output. Sounds reasonable, doesn't it? Respiratory systems wise, it is a significantly potent respiratory depressant. It literally just renders someone unwilling to breathe. They're going to take smaller breaths, they're going to take fewer breaths, or they're just not going to breathe. Like all other opiates, it desensitizes people to CO2, but also interestingly, alongside all the other opiates, although it's harder to give a big dose of, say, morphine to achieve this, you can get a wooden chest phenomenon. This is where someone gets really stiff, and therefore it's quite challenging to ventilate them. I'm sure there are documented cases of this happening with Remi, but also alfentanil and fentanyl. It's probably more likely to happen with Remi just because you can actually get away with giving such a massive dose because it's cleared out of the way quite quickly. Whereas if you give such a large dose of fentanyl to achieve a wooden chest phenomenon, it's going to be floating around in that person for quite some time. Now, there's a suggestion here that it is due to agonism of mu opioid receptors on GABAergic interneurons, i.e. those inhibitory interneurons that keep things calm. If you inhibit those, then things get jazzed up again, although I wouldn't get quoted on that if I were you. What do you do if you've given a stonking dose of Remi and then the patient's chest goes rigid? Well, you just paralyse them, and then you've undone the problem. So it's not a disaster. Perhaps just reflect on, did you really need to give that much Remi? What does it do to your central nervous system? Well, that bradycardia we mentioned from a cardiovascular perspective is vaguely mediated. It causes moderate sedation, and it's going to cause meiosis, as all opiates do, due to its fiddling around with the Edinger-Westphal nucleus. There is another important CNS effect of RemiFentanil that we see perhaps more than we do with other opiates, again, probably because we can just give so much more Remi and get away with it, is a situation whereby a patient is sensitized to pain stimuli following the withdrawal of RemiFentanil. We call it opioid-induced hyperalgesia. There's been a few studies on it, and actually I was recently listening to a podcast, i.e. yesterday, which explored this in further detail. This is called the Depth of Anesthesia podcast from David Howe. It's actually quite interesting looking at a bunch of different studies to try and explore the potential for RemiFentanil-induced hyperalgesia in mostly controlled groups. Here's a group of people having treatment, here's a group who isn't, but also having a look at patients who've actually had a laparotomy, these sorts of things. So I'd thoroughly recommend having a listen. I'll put a link to it in the show notes. But the crux of it is that RemiFentanil hyperalgesia exists, although it seems to ease within the first hour or so of a patient being post-op. They didn't allude to whether or not giving someone a dose of opiates smooths things out, but there's certainly a degree of an association with giving someone a Remi infusion and them being unexpectedly more sensitive to pain stimulus than those without a Remi infusion. It does seem to be still quite a rare thing to see. Patients just might look like they're in pain, when perhaps actually if they'd had a gas anaesthetic without RemiFentanil, they might be more comfortable in recovery. In the UK, it's standard practice to load a patient up with a non-RemiFentanil opiate before waking them up, i.e. give them some fentanyl, give them some morphine, make sure it's working as they're waking up, instead of just turning off the Remi and crossing your fingers. Anyway, we're digressing. A link to that in the show notes. It was a good episode. What about the GI side effects of RemiFentanil? Well, it's probably going to reduce your GI motility a bit. It might make people nauseous and sick, but bearing in mind that a lot of these side effects are going to diminish quite rapidly because the drug diminishes quite rapidly. So we've chatted about what the drug does to the person, pharmacodynamics. Now we need to have a bit of a think about what the body does to the drug, pharmacokinetics. So, how is it absorbed? Well, it's an intravenous drug. I couldn't tell you if it's orally absorbed. If it gets into your plasma, it's going to be chomped up by esterases before it probably does anything useful, unless you consume an inordinately large amount. But don't go eating RemiFentanil, guys. Just don't. How is it distributed once you've given someone an injection of RemiFentanil? Well, it is 70% protein bound. Approximately 2/3 of that to our dear friend alpha-1 glycoprotein. It has a really low measured volume of distribution, 0.1 litres per kilo, and it also will sneak across the placenta. It is 68% unionized at physiological pH. It has a pKa of 7.1. Now, we've noted that the volume of distribution I've quoted is 0.1 with a one-off dose. However, if you achieve a steady-state infusion, then the volume of distribution looks more like 0.25 to 0.5 litres per kilo. So this is now where we're really interested, is the metabolism of RemiFentanil. Now, you probably all know that it's rapidly cleared, and it is cleared by ester hydrolysis, and these are by esterases, enzymes. It's broken down chiefly by tissue esterases and also red blood cell esterases. And the important thing that makes this such a beautiful drug is that that ester linkage is involved in the drug being an effective opioid receptor agonist. So when it undergoes ester hydrolysis, the opioid binding bit of the molecule is rendered dysfunctional, which is super clever, isn't it? Now, it does break it down into a carboxylic acid derivative called remifentanil acid, and this has activity. However, it is 4,600 times less potent. So, whilst it has activity, I mean, it's, I don't know, pissing in the wind really compared to remifentanil. How does this play out in reality? So it has a context-sensitive half-time at 3 hours of 3.2 minutes, plus minus 0.9 of a minute, which is just bonkers really, isn't it? You could also think about it from the perspective of having about a 5 to a 14-minute elimination half-life. Due to the interminable abundance of plasma esterases, it is virtually impossible to saturate the enzyme system that clears remifentanil, and therefore the context-sensitive half-time at 3 hours, 3.2 minutes we'll say, is going to be the same as the context-sensitive half-time at 300 hours. Magic. I did try and find out if anyone has done the studies to try and saturate the esterase enzyme system, or if there's anyone out there who's managed to quantify the vastness of the real estate of plasma esterase lurking in a human. I couldn't find anything, but if anyone does know that, then please email me, because I'd love to read more about it. The clearance is 4.2 to 5 litres per minute, and that 4.2 to 5 litres per minute, that sounds exactly like an approximately normal shaped human's plasma volume, and that's because it is, guys, and it's independent of renal and hepatic function. Great drug. So we've got ourselves a drug that is really potent, has a rapid offset, and sounds great. So what are the pitfalls? So I think the first one that really jumps to my mind is this opioid-induced hyperalgesia. So don't just TIVA someone, they've had some local in the wound, and just think, I'll be fine. You know, it's probably reasonable to give them some extra pain relief there. But also, we've got a really potent drug that if you accidentally leave in a cannula, in one of those octopus things or whatever, and then someone dutifully flushes that octopus thing later down the line, you might have a patient who stops breathing. Now, I think I may have seen this happen, although it's very hard to be really sure. And the trouble is that if you stop breathing, you're going to accumulate CO2. If you're already in a semi-obtunded state because you're recovering from anaesthesia, where your sensitivity to CO2 might be a bit diminished already, you quite rapidly just become terribly disinterested in breathing. Now, this is transient because it's going to wear off, but you might find yourself for 5 minutes with a patient who isn't going to breathe, and if you don't recognise that and do something about it, it's important. So much like leaving paralysing agents in these octopus connectors because you forgot to flush it at the end of the case, RemiFentanil carries quite a high risk of that, so be super careful and vigilant when you're taking off your TV lines, make sure things are flushed. The other pitfall, or I would argue it's not really a pitfall because you should just be generally careful, is making sure you draw up the drug safely and appropriately at the right concentration so that you're not accidentally putting a double concentration into a pump and telling it that it's half the concentration, whereby you would end up with massive doses. But that's more down to being vigilant and having a structure for drawing up your drugs. So that, folks, is RemiFentanil. Now, there's a few papers linked in the show notes which go into lovely, elaborate detail. Obviously, when you're studying for this exam, you don't really want to be beavering down into several papers just on one drug because there's just so much to learn. You're drinking from a fire hose. But, if you're bored, have a look. And now we're going to go on to the second part of the show. So maybe take a breather, pause, go and have a drink, make a cup of tea, cross that roundabout safely. We're going to talk about the Minto TCI model for administering RemiFentanil. So now we need to talk about how we actually go about putting RemiFentanil into people. So you're probably just thinking, why did they even bother with a target control infusion model? Why don't you just give a mic per kilo per minute dose and just call it there? Well, for a number of reasons. One, this drug is rapidly metabolized, so if you're not giving enough, you're not really going to achieve an effect. Two, a mic per kilo per minute dose isn't age adjusted, and there's a fair wad of evidence to suggest that the susceptibility of a young person to Remi is very much less than the susceptibility of an older person to RemiFentanil. So if you're giving everyone 5 mics per kilo per minute for that laparotomy, you're actually really overdosing the old folk, or perhaps underdosing the young folk. Furthermore, we all understand a few bits and pieces about pharmacology, and we know that it takes 4.5 half-lives to achieve steady state. And as the half-life is 3 to 5 minutes, we're looking at 15 minutes to achieve steady state. So here we are, we're anaesthetising someone, and we think, right, okay, now let's get our mics per kilo per minute dose going. And it's trickling in, dabbling in down that syringe driver. Are we going to wait 15 minutes before we reach the target? No, you would turn the mics per kilo per minute dose all the way up and then wait less time. Except for now, you run the risk of overdosing the patient if you forget to then turn it back down again. All very awkward. And remembering, guys, that this drug has a blisteringly fast onset time if you give a bolus, so you'd feel like you're just chasing your tail. That's where having a computer do the heavy lifting for you makes your life far, far easier. And we shouldn't be afraid of computers, even if they're going to take our jobs. So, our dear fellow Minto comes along and thinks, you know what, RemiFentanil, that's ripe for making a name for myself, and a name for himself he has. As with every pharmacokinetic model, it takes variables into account. The variables chiefly used by the Minto model are age, weight, and sex. It then works out lean body mass to guide its dosing. So the original paper describing the development of the model utilised 65 adults, 20 to 85 years of age, having constant infusions of between 1 and 8 mics per kilo per minute. They had arterial lines in, they took loads of samples and continued to take samples for 4 hours after the cessation of infusion. They took these blood samples and then immediately tipped in something called acetonitrile into the sample to inhibit the esterase activity, because otherwise if you've got loads of samples just sat on the side, well, unsurprisingly, all the Remi's just going to get eaten up because the metabolic activity is happening right there in the plasma. Cool drug. So the chief thing this initial paper describes is that the covariates of note were age and lean body mass, and gender in itself hadn't really got any influence on the plasma concentrations of RemiFentanil. However, you need to know the gender to subsequently calculate the patient's lean body mass. They also found that the EC50, and they were doing this by using an EEG and deciding how asleep someone was based on EEG findings, that the effect site requirements dropped by 50% across the age range from a 20-year-old to an 85-year-old. So an 85-year-old required half the amount of drug to achieve the same amount of suppression of brain. So if you're doing that mic per kilo per minute dosing in dear Mildred, who's having her knee done, you're probably overdosing, unless you're exceedingly careful. So then we're like, oh, we're talking about multi-compartmental models here, aren't we? Yes, of course we are. So there are volumes in such a model, aren't there? And V1 and V2 vary with lean body mass, i.e. the plasma compartment and the compartment that has lots of blood flow, the highly vascular compartment, V2. V3 is fixed at 5.42 litres, and that's because it probably doesn't have a massive role. Not much drug ends up there. Now, clearance is directly from the plasma because of those esterases, but remember there are clearances between all these compartments, and I'll tell you that the V1 compartment, the clearance is dictated by the patient's age and their lean body mass, whereas the V2 and V3 compartments are adjusted for age only. Now, there's an interesting sort of semi-dichotomous balance that bears out with patients. So older folk have a smaller central compartment. Remember, older folk are less watery, more fatty, if we're putting things into simple terms. So therefore, the same dose would actually achieve a higher initial concentration in that central compartment because it's smaller. And you'd say, well, that means a bigger dose means a bigger effect. However, the onset time of RemiFentanil in an older person is actually slower. It takes longer to get where it needs to go. Therefore, it smooths out that spike and you don't actually see that much of a change when you're giving an age-appropriate dose of RemiFentanil. This bears out when you think about the peak effect. So the peak effect has been measured in a 20-year-old. Give them a bolus of RemiFentanil. It takes just about a minute for you to see peak effect, whereas in an 80-year-old patient, it takes 2.5 minutes, more or less, to achieve peak effect. Their cardiovascular system is not as dynamic as perhaps a younger person's cardiovascular system. And then try and quickly move on, instead of them asking, oh, what do you mean by dynamic? In which case, you've got to try and fudge along saying, well, they probably have a reduced cardiac output compared to them when they were a younger person, etc., etc. What about in some clinical uses and extremes? So if we had a really, really obese patient and we plumbed their numbers into our lean body mass calculator, it may actually end up underdosing the patient because we all know that really heavy people do have more plasma and it doesn't scale in a linear manner. So you may find that in a really overweight person, Minto actually overdoses them. Again, go to your sober app, run their height and weight into there. It'll give you all the adjusted body weight 40 sort of jazz. And this is that similar situation that you find yourself with the Schneider models using the James equation to calculate lean body mass because it falls down at BMIs over 40. And just so we're explicitly clear, the sober app recommends using the adjusted body weight 40 for RemiFentanil TCI to try and balance this problem out. Now it's important quickly here to digress about this magical machine that does dosing for us and the rigidity to which we might hold ourselves to a certain concentration and deem that, oh yes, when I do laparotomies, I go for an effect site of 6 nanograms per mil. Bam, done. Now, every patient is different, and actually if you look at the second paper from the Minto folks looking at some simulations of the actual true range, it's quite tremendously divergent. And I think it's more important that we all remember that this is a useful and handy machine that gets us to a steady state concentration which yields a clinical effect. And if that clinical effect is the one we like, then we should stick with where we are. And if it is insufficient and the patient clearly appears to be in pain with a tachycardia and hypertension, and they're not aware, remember guys, the drug actually has to go in the patient, then we need to turn it up. And you might say, oh, well, but I don't go above 6 when I do my laparotomies, but this patient's in gibbering agony. Well, that's you letting the machine do all the work and not thinking about it in greater detail. So it is a tool that allows you to reach convenient steady states that bear out in pharmacokinetic reality, more or less. So some patients need more, some patients need less. Don't be rigid. And it's worth, when you're doing these sorts of infusions, once you've reached a steady state, looking at the mic per kilo per minute dose and getting a feel for what that bears out compared to what you might expect. This is also useful in case you have pump failure, and then you can quickly just chuck it on a syringe driver and continue it at that same mils per hour mic per kilo rate and not have to do too much maths in the event of bother. Anyway, thanks for listening, guys. That's a little bit of an intro to Minto. We covered RemiFentanil in reasonable detail. It's a really cool drug. I think it's going to be used more and more and more to avoid having to paralyse people, because you can get them deep on Remi and they do very much relax. And you can sneak that tube in without having to paralyse them, which means you avoid all the problems of having to reverse them at the end and post-op pulmonary complications of microaspiration, etc., that don't crop up for a week once the patient's at home and then they get a chest infection. Always worth having some paralysis to hand, though, just in case they go very rigid. Those pesky patients. Righto. Have a nice week. If you enjoyed the episode, please, maybe stick a rating on, like, subscribe, tell your friends, drop me an email. If you find a gap or something that needs to be covered in greater detail or double-checked on, you will be immortalised in this podcast in the show notes or right here in the audio if you've contributed and helped me get a clearer message across for everyone else. Thank you very much for listening. Bye. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.